Well, it's good afternoon, everybody. Nice to see you all. We are, well, Chris will be, handing out some voting pads now. So please don't worry, the voting's anonymised. I don't know who's saying what. I don't pick on anybody, okay? Seriously, I don't, even those on the front row. Okay, and we've already just been talking outside. I'll introduce myself. My name's Joy Tickle, tissue viability specialist in Shropshire for 23 years. I'll just get the puns out the way now. No, I haven't starred in any carry-on films with a name like Tickle, but I could do. And I've heard all the jokes, but it's a nice name to have, isn't it? Apart from if you hurt the patients and then they say you don't tickle anymore. So no, I haven't made that name up, but I am very passionate about wounds. I love tissue viability, hence I've stayed in practice for 23 years in the specialism and have no plans to go anywhere until I retire, hopefully. So that's a little bit about me. What I'm hoping to do today is to share with you two sessions, one before lunch, one after lunch. So if you don't come back after lunch, I know I've done something really wrong, and I shall chase you all down the high street. Introducing best practice, and I know best practice, sometimes we say, what is best practice? What is gold standard? And it's not Joy Tickle harping on, this is best practice. I'm going to give you the evidence, okay? The evidence that you may already be carrying out in your own work areas, evidence that you want to introduce into your own workplace, and evidence that actually you can challenge with in your own workplace, okay? And hopefully put that into practical terms, because I'm very practical, I'm hands-on. I was in clinic yesterday and I'll be in clinic tomorrow. I can't stand here and talk to you guys if I haven't got that patient with me, okay? And I feel I would be doing you a real disservice if I was doing that. So my first session is around venous leg ulcerations virtual clinic, but we're going to look at first the ulcer itself, around the actual wound assessment and management, and then after the break, then take that patient journey into the evidence-based compression therapy and how we can help you. I think we're all aware every moment matters. You know, I do like that saying because every moment does matter. It doesn't matter what grade you are, in my opinion. It doesn't matter how many years of experience you have or do not have. You're just as important in that patient's care pathway, okay, and treatment pathway. Every single time we meet that patient for whatever reason, that little bit of element of it will matter. So on your voting pads, just for a taster, I like to know, you know who I am. I like to know a little bit more about who I'm speaking with. So on your voting pads, what is your role in your organisation? Tissue viability nurse or other specialist, staff nurse, hospital nurse, district community, practice, I'm sure you can all read, but I just do go through them. Healthcare assistant, associate practitioner, nursing home or care home, or other. So if you can vote for me, that would be fab. Yeah, you've all got one, so let's have a little look where you're all from. I think you're all from this area, I do gather that, not me like 2 hours down the motorway. Okay, so we've got some specialist nurses in the audience, brilliant, thank you, and I'm probably talking to the converted, but hey ho, it's nice to share that. Some acute hospital staff, that's brilliant. Community, yeah, because let's be honest, a lot of wound care is carried out in the community setting, but I totally agree, in the acute setting as well. Practice nurse, no practice nurses today. We have, but you've put yourself as community. Oh, wow. Did I not? We were testing you. But lovely to see the practice nurses in the audience because, again, you know, millions of visits per year for wound care to your practices. Not just yours, but across the UK. Healthcare assistants. Any healthcare assistants? Yeah, sorry about the voting. Associate practitioners? No? Yeah. I welcome you, okay? Because I'm aware, in our county as well, recruitment of nurses now is on its way down. Retention of staff is certainly in our area. You know, the demands, we need to think about upskilling our HCAs, associate practitioners, you know, come on, we're a team, okay? And hopefully I'm going to share some practical skills, practical evidence, with you that can look at that wider skill mix as well. Nursing home staff, care home staff, I cover I do, but my team of 3 for the whole of Shropshire do cover care home, so it's lovely to see you guys here. Can I ask who other is? Students, yay! So how much time do you get during your course, ladies, gents, on wound care? 1 day out of 3 and a bit years? Yeah, so you can see why. And then you put that nice coloured uniform on when you qualify, and you're supposed to be an expert. Well, not expert, but you're supposed to have that really good knowledge base, aren't you? So thank you for coming today, because I know it is difficult. Other show of hands for other? Any others? Sorry, guys at the back. Podiatry is great. I'm speaking at our diabetic foot conference tomorrow. I couldn't do it without you guys. So can you see about that? Every moment matters. It doesn't matter where we work, what colour uniform we wear. It's sharing that and working with that patient. So thank you for sharing that with me. So what percentage of time do you spend within your own sort of areas and caseloads treating leg wounds then? And for podiatrists in the audience, we'll talk about foot wounds as well, because I'm sure I'm not saying don't see leg wounds as well. So this can vary. I totally respect that on your work environment. So 0 to 25%, 25 to 50. You can vote now, by the way. 50 to 75, 75 to 100. It's just approximate. It's just roughly, I'm just seeing how much time you're actually spending caring for patients with limb wounds or leg wounds. Okay. So I'll give you a little bit longer, because Chris said I was a little bit too premature on closing the voting last time. I'd be no good on those reality TV programmes, would I? Dunk, closed. Okay. So I'm going to close the vote now on that, so don't worry too much. It's just, again, to get a feel of how much time we're spending. And I totally agree with that. It's mixed. It depends on where you work. It depends on your role. But as you can see, quite a lot of you are spending, anything between 25 and look at that 75%, 75 to 100%. 7% of you guys are spending that amount of time. I can link that to some of the podiatrists in the audience and your specialists in the audience as well. But that's a lot of time, isn't it, on your caseload? And to me, the cost is enormous to organisations. We know that. Julian Guest's work, he's doing lots and lots of work, and I'm going to go into some of those facts, Bowden and Bowden, about the health economical burden of wounds. So the health economical burden is for organisations delivering wound care. The demands are the practitioners delivering the health care, so your time and your resources, and the most expensive commodity in wound care is what? You guys, yeah? Okay, and rightfully so. But what about that impact on the patient? To me, the biggest cost is to our patients. How many of you, roughly, do you think that on average patients are living with a chronic wound? How long do you think they have a chronic wound for? 3 months? 6? It's 2 years, guys. In 2018, our patients on average with a chronic wound have it for 2 years. Can you imagine yourselves now? Because we're all imagining, if you close your eyes, an elderly person. Take at least 20 years off that elderly person. Imagine living with a chronic wound for 2 years. The impact on your relationships with your partner, with your children, with your grandchildren. Can you take them swimming? Can you do exercise? Can you go on holiday? Can you walk on the beach? Can you go to work? I have to go to work. I need to work. Financially, I can't afford not to work. But I go to work and people turn the nose up at me because my leg smells, or I'm trying to mask the smell of the wound with other things. It's a massive, massive impact, and I can totally understand why patients do suffer with anxiety and depression. And I've referred many patients during my career for counselling and support with problems with chronicity of wounds. That problem isn't going to go away. If anything, it's envisaged now that by 2020 and onwards, the number of chronic wounds is going to increase. Now, we can all try and establish why that may be, patients living longer, older population, multiple comorbidities, all of those factors. But again, this is where we're having to address now how we can implement best practice, but also make it more simpler. These are some guesswork findings, should I say. 730 patients affected with a lower limb in a year. Okay, 730,000 patients. Okay, that's 1.5% of the adult population. And if we work on averages that the over 85s is likely to double in the next 20 years, that figure is going to significantly increase. Okay. I might be retired in a few years and I'll be the world's worst patient. So I do warn our community nurses and TVNs in the area, if you come to me and I've got a leg wound, I'm going to be horrible. So they'll have to draw straws. But what I'm saying is, particularly, you know, over the next 10, 20 years, this is going to be a massive problem if we don't address it. The bit that worried me out of guests' findings was this bit. Out of all of those patients, 16% of the cases of the limb wounds identified throughout the UK had only 16% had only had a Doppler or an ankle brachial pressure index. Does that surprise you? When we're saying that doing you know, establishing arterial flow is a gold standard to whether we put compression on or not. So that means that the other 84% are either not in compression, or some of them are not in compression and should be. And I would say the latter, that they're in compression. Okay, but they haven't had an ABPI. Now, I know we've had some really good presentations of how we can now, with new tools and new equipment, speed up that process. And don't get me wrong, I'm a big believer, ABPIs are about is one part of the assessment of the patient. It's the holistic assessment of that patient with the wound. But it did concern me somewhat when I saw that. But it's not unusual. That is not unusual. So 730,000 people, I was trying to put that in context. How many people is that, you know? And it's hard to visualise, isn't it? But that's the entire population of Harrogate, plus Cardiff, plus Aberdeen, plus Antrim. So it's massive, isn't it? Massive amount of people. But I'm sure all we care about, no disrespect, is those patients that are in our cohort. And those patients could be your relatives, could be your brother, your sister, your family member. And I talked to you about, we associate leg ulcers with the older population. Yes, the ageing process, multiple comorbidities, polypharmacy, all links into the reasons why they do develop or could develop limb wounds and why they're slow to heal. But what I want you to do now is think about the younger population. Who read in the press about that young teenager who died recently? He was he 16? And he was obese and quite immobile, and like my son, who likes to play game consoles, sat, got a DVT and died as a consequence. That sounds extreme, I know, but this is our younger population. We know there's going to be a problem with obesity, bariatric, but these are our younger population who are going to be our next leg ulcer patients. And the youngest patient in my clinic at the moment is 18. You know, and we've got to think a little bit outside the boxes in the sense that we're not just waiting. And these elderly patients that you may see, on average maybe 75, 80, but I'll guarantee you if they've got true venous disease, they started a good 20, 30 years ago, potentially when they had their children, for the women, that is, not the men. So pregnancy, big contributing factor. But do we start there? No. How many of us, I know I'd love to have time to go and speak to antenatal classes about wearing support and compression. Again, it's where do we start? So back to you. What are your main clinical challenges when managing leg ulcers? And I've been cruel here because I could have put it at the very bottom, all of the above, but that's a get out clause, isn't it? Because we'd all put all of the above. But just vote for me. You know, you probably, all of those are a challenge to you, but when you see those words, which one makes you think, oh, that's going to be a bit of a challenge? Is it necrotic and sloughy tissue, excessive moisture, edema, infection, or hyperkeratosis, that scaly, dry, built-up skin that then can become wet? So again, I'm sure it will vary from where you work and what sort of limbs you see. But just to get that discussion, you know, going, I'd like to just see what your challenges are. And I'm going to move that on because obviously I am sure you won't want me to delay your lunch in any way. So I agree with all of those. When I'm looking after any of my patients with lower limb problems, all of those can be a challenge, some more than others, okay? But I agree with you. I think that necrotic and sloughy tissue, we have to start there, don't we? Because sloughy and devitalised tissue, you know, can then lead on to increased exudate, which then leads on to excessive moisture, which can then increase bacterial burden, which then leads on to a potential infection or localised infection, okay? And it's a cycle, isn't it? But I agree, all of them can be a problem. Challenges of leg ulcer, we've just said. Exudate levels when a patient, and this to me, most of these are, you know, from a point of view of exudate, is the one that distresses the patient most. So we go in and we set objectives, don't we, with our, you know, well, in our heads we've got our objectives. I'm going to heal your leg ulcer. And I said I'd pick on you on the front row, so I have to think of something to give you. But, you know, my objective is, yes, overall I want to heal your leg ulcer. But that may not be your first objective. Have I asked you what your first objective is? Have I engaged with you and said, you know, that patient engagement? Because you'll turn to me and probably say, that's not my first choice. I want you to stop it leaking. I want to be able to put my shoes on or wear clothes where I'm not worried, black clothes, because it doesn't show staining. When one of my patients came to clinic, not met her before, came on voluntary transport, walked into the clinic doors, burst into tears and said she was never coming again. I thought probably the thought of my face, maybe, but joking apart, we took her into a room and she was upset. The story goes she came on voluntary transport, she has a leg wound that's very exuding, very weepy. She's tried everything to stop it leaking, the nurses are trying everything to stop it leaking. She comes in the voluntary car, she gets out the voluntary car and the driver stops and said, "Excuse me, love, I think you've wet yourself." Because on the seat at the back was a wet patch where her leg had leaked, but he assumed she'd wet herself. She's local, so the voluntary drivers know everybody. So she's mortified that this driver feels that she's wet herself in the back of the cab, in the back of the car. See that big impact? So to her, I could talk to her first visit, yes, we can heal this wound and we're going to do this. No. Her first objective is, don't let me have to worry about my limb leaking. Now, of course, we then went out, I did anyway, and purposely spoke to the voluntary driver about confidentiality and put him straight, really, that hadn't happened. But you can imagine, can't you, standing in a queue in the supermarket and somebody saying, "Excuse me, I think you're leaking," or "What's that smell?" And I've seen it for myself. So exudate can be a massive problem. It's a massive, and I'm sure some of you guys will think, oh yeah, it's a problem for us as clinicians of how we manage that. You know, we're talking about this really good wound management, but actually, how do we manage the exudate? So I'll talk to you about those challenges in more detail. The other one is infection, isn't it? Infection and biofilms. And again, I'm going to talk a little bit around devitalised tissue and biofilms later. But again, that is a challenge. It certainly is a challenge for me as a clinician. Fluid and edema, again, because we are specifically talking about venous leg ulcers this morning. Time won't allow me to go into all the other etiologies, but edema is associated with venous disease, isn't it? You know, that raised pressure in the venous system, the skin changes, the chronic inflammation and the dependency and edema as well, due to the venous hypertension. Concordance, do we call it concordance? Do we call it compliance? I know that's a debate at the moment. I just say, what are the patient issues? If the patient's taking the compression off, there's a reason, okay? Do they understand why they're wearing it? Patient said to me recently, I take those compression bandages off, they're only to hold me dressing in and they drive me mad. She only thinks that the compression bandages are to hold the dressing in place. We need to educate that they have a disease. They have venous disease, which means they have in a nutshell, because I've only got an hour, they have venous return, they have poor venous return, so the blood's flowing lovely through the arteries, some of it's returning back up to the heart, but because of the problems within the venous system, that be the veins or the valves, some of that is pooling in the lower part of the leg, the gaiter region. That then means they have a raised pressure, they'll start to have chronic skin changes, chronic limb distortion changes, and potential ulcers. They feel the ulcer is the cause. The ulcer is never the cause of VLUs. It's the venous disease. So if I told you you're diabetic, and you had to take insulin because you have diabetes disease, you would do it, wouldn't you? Hopefully. Majority of people would get that. I need that. So I say to you, you've got venous disease, and you have to wear compression to correct that venous disease, and it's for life. Would you understand that better than me just saying you've got an ulcer and we'll heal it? Because the disease is for life, guys. Start from day one when you meet them. If it's true VLUs and they've got venous skin changes and venous disease, they'll have it for life. Okay? And again, is concordance because they're being difficult, or is non-concordance because they don't understand? Okay? Even when it comes to cleansing of the wounds, using your wound products, tell them why. They're interested. Google's a wonderful thing, isn't it? It can be a bad thing as well when they ask you to put all sorts of horse chestnut rubs on the wound and all sorts of things. But, you know, give them the advice. Time is an issue, isn't it? That's a big issue for us in Shropshire, and I'm sure it's no different down here in Bristol. You know, we've got to do more with less staff. We've got to cost less, and we've got to save money on the same time, and income generator, wonderful. It isn't going to go away, unfortunately. So, you know, I get that, guys. When we say about holistic assessment, ideal, have an hour. Oh, you're joking, Joy. When practice nurses are allocated, not themselves, they are allocated 10-minute slots with their patients. When district nurses, you know, have that that caseload, 20 minutes for this patient, 30, it doesn't work that way in care, does it? You know, we've gone too much time allocation task orientated, I feel, but that's me on my soapbox. And I think, you know, patient assessment, patient care is not about in little time boxes, but how could we do it a little bit more timely? Because, you know, they're not going to give us more time. But how can we challenge that, though, to make it differently? I know there's lots and lots of more challenges out there, but today, because of time, I'm going to concentrate on two main challenges. What I will refer you to, though, is the best practice statement, the holistic management of venous leg ulcers. This was released last year. This isn't, you know, it's a panel of experts, vascular nurse, podiatry, TVNs, who came together with to gather all of the evidence around venous leg ulcers. Because you admit, I'm the same. I have journals at the side of me. Must read that article, must read that article. And I only work in tissue viability. So for all of you generic nurses, you've got to learn this about catheterization. You don't ever get round, I don't ever get round to it. So what the group did, the experts did, was get that evidence. Old evidence, new evidence. Look at myths and truths, what's new, what's old, and put it in a usable document for you. So you haven't got to go through, or, yeah, read them if you want to, but let's get the evidence for you and make it in a usable document that involves the patient as well. And this document very much centres around self-care, which we'll talk a little bit more about in depth after coffee, dinner even. Wound bed preparation then. I want to start with this, and I can't talk through them all, but TIMES is an acronym. It's a tool. You can use it or you cannot use it. There's lots of good acronyms out there, but what it is basically, it's a simple method of wound assessment and wound bed preparation that if you address each one of those TIMES, will help you to remove the barriers of wound healing, okay? Because if we can remove those barriers, there's a good chance the wounds will start to move along the healing continuum. Okay, so T is for tissue or devitalized tissue, I is for infection or inflammation, M is for moisture balance, E is for the edge of the wound or any undermining, and S is for skin. Now, it used to be time, but we, in the best practice panel, decided to change it to S, add an S on the end, because we found that peri-wound skin, surrounding skin, particularly VLUs, that hyperkeratosis and that dry skin, was a problem. And we needed to build that into your assessment tool and your removal of barriers. So for today's session, I'm concentrating on just the two, but I will direct you to that. You can download it free of charge on the Wounds UK site. Go to the L&R stand. They've got them on the stands. They were involved in helping us to produce that. And also you'll have these on your seats after lunch, and it's a quick guide to your time. So everything I'm talking about, guys, don't worry, it's all just in there. I think I should walk around with times tattooed on my head. I'd look a bit strange, but every time I look at a patient or a wound, so I'm picking on you girls in the audience as well, I just look and I think time straight away, because it is in my assessment document, electronically or handheld, but in my head I'm looking at the patient's wound and I'm thinking times, and I'll go through each one. And if I address each one and assess each one, hopefully, and if reassessment, I'll say times again, and if something's not quite working, then I'll change it and I'll change my objectives. But tissue, right, why do we need to remove that slough and devitalise tissue for a wound bed? I've given you most of the answers, and I'm sure you already know them. Again, I'm talking to the converted. It's a physical barrier to healing, okay? Slough and devitalised tissue will contain waste products, dead white blood cells, all sorts of, it could be, if it's from a trauma, any bacteria in there. Wounds will always have bacteria, or should I say microorganisms, because it's not just bacteria in wounds. We're changing the word bacteria now. It's microorganisms. There could be fungi in there, there could be viruses in there, or proteoas. So just bearing that in mind. But there always will be. But it's when they become harmful or multiply, they'll become a problem. So it's a physical barrier. We have to remove that. It can mask or mimic the signs of infection. So I have a necrotic wound, okay, or some dry necrotic tissue across a wound bed. It's dead tissue. My body's really clever. It doesn't like dead tissue. It's already my body is telling me I need to try and break that down. So autolysis start to kick in. So I will then send more fluid to that site, because that fluid's carrying white blood cells and phagocytes and macrophages that are going to break that devitalised tissue down. When that happens, what happens to my wound area? Becomes a little bit wetter, may exude more, might be a bit inflamed, might be a bit more painful for the patient. What are those signs and symptoms of? Also, possible infection. So you can understand why our patients then go, I've got an infection, I need antibiotics. Or sometimes as clinicians we go, that's infected. It can mimic or mask those signs of infection. Diabetic foot ulcers or diabetic wounds, because of the higher risk of infection, because of the process of the diabetes, they can mask signs of infection. So where we get those cardinal signs of infection, your diabetic patient may not. So again, we need to remove that devitalised tissue. It's absolutely breeding ground for microorganisms. It's the soup of all. They love it. They will party there. They will multiply. Devitalised tissue is what the bacteria and microorganisms will love. So if we reduce the devitalised tissue, reduce the bacterial burden and microorganisms. Can prevent effectiveness of topical treatment. So you visualise now a necrotic wound or a dry eschar, a brown eschar across a wound that's dry, and you come along with your really good dressing because you've just you've seen them all out there, and it'll do this and it'll do that. If you don't remove that eschar, is it working, or shall we just put it on that brick wall? Because that's what you've got to imagine. You've got to break down that so the properties of the dressing, which are very good, can do their job. Okay. It can underestimate wound extent. How many of you have seen a ungradable pressure ulcer? Just a show of hands. And when that devitalised tissue is removed, it's about 7 centimetres deep, hopefully not, or 3. Did you know the true depth when you first saw that wound? No, you didn't. So it's going to you're going to underestimate. You can't measure it. You won't get a true length or width either, because I'll guarantee you when that device slough or tissue is removed, it will be longer and it will be wider, and potentially there'll be undermining. So you can, and I agree with you, you can only assess what you can see. If you can't see it, you can't assess it, but regular reassessment and measurements of wound is gold standard. But it's difficult to do if you've got that area. How many of you warn your patients and your carers that when this devitalised tissue is removed, this wound may look bigger and deeper? How many times I've been accused of making somebody's wound worse, okay, because I've removed devitalised tissue without warning them. And that's my error because I haven't pre-emptied and pre-warmed them. So even if you're using products for autolysis, warn them. The wound may look bigger and it may look deeper because you're removing that dead tissue and you can see the true extent. That's why regular wound measurements with the same tool and photography really help in that instance. And of course, the longer the microorganisms are there, the longer the devitalized tissue is there, those microorganisms increase, and guess what? Risk of systemic infection as well as localized, and then potential septic response. And I was devastated this year to have my first patient who died from sepsis from a wound, and he was only 54. There was other things going on, I appreciate, but on his death certificate, it was sepsis from a wound. Okay, and you know, I know we say don't take it personally, but I think it, you know, in healthcare we do sometimes. So why is it important? I've just talked at length about those, and I'm not going to go on about those. But what I will say with tissue as well is don't forget, not just infection, just think about reducing the bacterial burden by removing that devitalized tissue. So for instance, biofilms. How many of you truly understand biofilms? I'm going to put my hand up. I don't really, but I do. I do, but I don't, if you know what I mean. And that's what, 2 of us in the audience then, who put our hands up then. And I work in the field every day, okay? But biofilms, you know, they're not new, they have been around. But if I'm going to tell it you in a nutshell, and literally 2 minutes flat, but what I will say is there's some really good modules online. Al and I have got a really good video about biofilms. Biofilms are a casing, okay, that's how I put it. Because I'm from Stoke. I don't know if you can get the twang, but I'm from Stoke. So we all have bacteria, okay? But bacteria on a wound will multiply. Of course they will. You know, they're having a party. They've got the nice ideal environment, moist, etc. So they'll multiply. Now normally our own bodies, our own antibodies, will migrate to that site of increased bacteria and will destroy them. So these bacteria are planktonic. They're free floating. They're just wandering around having a great party. Some of them will reside there though, some of them won't be destroyed, and they'll latch onto the collagen in the wound bed, okay, and then they'll start to multiply. They very commonly will latch onto sites such as prosthesis sites, so hip replacements, peg sites, and you often see, you know, got that peg site that constantly seems sloughy, and they'll start to reproduce. But what happens in the meantime is when they're hidden and they're starting to reproduce, very quickly, biofilms can form, and what biofilms are is extracellular matrix made up of carbohydrates and proteins that encase that bacteria. So imagine now you've got a nice little shell around you, okay, and it's a hard shell, and nothing can get in it. So your body's trying to fight it, and your antibodies migrate there, but they can't get through. I give you some antibiotics, that'll work. Can't get through. I'll put an antimicrobial dressing on as well. But that can't work, not because it's no good, just can't get through. Okay, so what am I going to do? So this morning, all of you woke up and you had biofilms in your mouth. Okay, so you're going to do that now. Might have one now growing. Okay, and you did, because it's overnight, bacteria's multiplied, sat where it's moist and nice and warm and dark, and lay on your teeth. What did you do? Hopefully, you don't have to shout if you didn't. I won't pick on you, really. Not. Did you get your toothpaste that's antimicrobial, whitening, gum protection, and just put it on your teeth? You got it, yeah. Did you just put it on your teeth and then come out? No. Why? It says it's going to kill the bacteria, make your teeth nice and white. You got your toothbrush. Why did you use your toothbrush? Because you broke down the biofilm. Then your super toothpaste can get to the source and do what it's just the same with your wounds. You have to break down mechanically those biofilms. There's various methods you can break them down. Anybody debride in the audience, put show of hands. Now, at the end of my session, you can all put your hands up because you all debride. We just all assume debridement has to be sharp with blades and scalpels and trained for. So if you wait for me to come and sharp debride one of your wounds, you may be waiting a week or so. Can we wait that long? Does the patient's risk factors allow us to wait that long? Have you got time as a clinician? We may use products to autolytically debride. Okay, so you may use your wound dressing products, you may use cleansing agents such as octanoline and prontastan if necessary. I'm not saying for all your patients, but where you want to break that biofilm down so your primary dressing can work. Okay, you may use maggots. Any of you use maggots in Bristol? Yeah, good. Maggots are brilliant. They'll only eat devitalised tissue, because a lot of nurses think, or clinicians should I say, they're going to eat the good skin, don't want the good healthy tissue, they only want the bad. Okay, how long can you wait to get maggots for? Who's going to fund it? You've got to use it within a certain time period. The most adverse problem is the nurses, not actually the patients. Got to be in an area on the body that they can use them. And my first error as a sister was maggots on that heel till the patient stood on them. And I didn't think about offloading, and she squashed them as soon as I put them on. So poor maggots died in an instant. Okay, but we've got lots of different processes, but you need something quick. You need something that all of your team can use and not wait for the TVN or Joy Tickle or somebody or the maggots to come through Royal Mail or whatever, the way they come. So one of the things we looked at in Shropshire was that whole process. So we introduced the monofilament pad. So any of you use the Debrisoft pads? Or lollipops, yeah, so half and half really. And I'm going to be really honest, and I'm sorry for the L&R guys in the audience. When I first saw this, and gosh, I'm going back now, a good bit of time now, when I first saw the monofilament pads and read the evidence, because it is NICE endorsed, by the way, I thought, how's that going to break down that devitalised tissue? Not just the slough, but also peri-wound hyperkeratosis and all the things it says it's done. It's really soft, and I actually thought, that's quite a nice cleansing pad. But actually, it's the science behind it. There's millions of monofilaments in here that it's not an antimicrobial, it's not a dressing, okay? What it does is, through pre-moistening, I'm not going to tell you how to use it, go to the L&R stand, watch the L&R presentations online. It's just that circular motion, and what you're doing is trapping, you're breaking it down first of all, the devitalised tissue and the biofilms, and then you're trapping it into the pad. So it's a debridement pad, and they do the lolly as well. And you're just trapping it. So what you're doing is removing that barrier, okay? So it's not a dressing, you're removing the barrier so that when you put your dressing on, it can actually then treat the source, okay? Do I need to be an RGN to use this form of debridement? Or qualified practitioner, should I say. Can your patients use it? Of course they can. Can your carers use it? Of course they can, with advice and support. I see lots of children in my job, and if I go towards our children in the community with a forceps and a pair of scissors, not only will the child probably want to hit me, so will the mother or the father, okay? Can I give a child that to do and show them how to do it? Of course you can. Can you skill mix in your team now? So if you need to debride a wound, we're all doing it. Every moment matters. Okay, so think about that. And you can see, well, you can't see, because I haven't put the slide up yet, but I'll show you a picture of before and after. But there's lots of evidence around that. So this isn't Joy Tickle just standing up here and saying this. This is recognised in best practice. It's recognised by NICE. There's lots of papers out there about the actions of these monofilaments, okay, and how quick it can be. And there was a Debrisoft challenge, so it was just under 2,000 clinicians who wrote in and didn't write in, emailed in and reported. So it was nothing to do with the company. We all took up this challenge. And these were the overall findings. And as you can see, not just for tissue, it helped to reduce the biofilm, so there was less local signs of infections. If there was less bacteria, guess what? The moisture levels improved. Okay, so they weren't excessive. Surrounding skin became better, and all those changes. So just one simple technique of debridement can make such a difference. And you can see here, these were the clinician's words. But if you look at that wound on your left, you might see that patient, postcellulitis, got a leg ulcer, come under your care, cellulitis is resolving. As a team leader, I'm thinking, oh gosh, that's going to need lots of soak. By the way, I'm a big believer of soaking and washing legs as well. Okay, not feet if the DFU's podiatry in the audience, but definitely legs. Okay, so and I'm a picker. because that's why I went into tissue viability, and I love to squeeze spots. But equally on that point, we don't have time, do we? Not like we used to. So I would still wash and all that, but I want something quick. So I look at that limb and I think, gosh, I'm going to have to bandage that limb. That's going to be an extensive wound. I'm going to plan my team's work. That's going to be an RGN going in, compression bandaging, 3 minutes later from the Debris Soft challenge, okay? Now, superficial wound. Little bit of quite a bit of hyperkeratosis, dry skin, superficial wound, not really exuding much. Nice slim leg. Do I need bandaging? No, I don't. Can put them in hosiery kits. Okay. Do I need an RGN to go in and care for that limb? No. See where I'm coming from? That's skill mix and using the evidence there around it. Chris is going to kill me. He's gone out the room now. Chris keeps us on time sometimes, and I've already lost the challenge this year. So moisture. So the two key points I'm just doing today, please read around the times though if you're not already using it, because you may be. Moisture balance. So on average, guys, with your voting pads, what's the most likely frequency of dressing change in your practice? And it will vary, I get that. So with your voting pads, and I think I have opened the vote. Somebody vote for me, unless I haven't. Should be open. There we go. So is it once a week, twice a week, 3 times a week, or 4 or more? And it will vary. I know you've all got different wounds, but if you're thinking about the average patient, and I hate the word average, but the average patient really. Okay, I'm going to keep the voting fairly short, so I do apologise because I just don't want you to overrun too much, or I will overrun too much, should I say. I think 59% is about right in our community where I work. It's on average, most clinicians aim for twice a week. And if I'm being honest, it's because of time factors as well. It isn't just about best practice. I think there's quite a few patients with VLUs are on 3 times a week, normally around to do with exudate, moisture and skincare. And then some of the very large edematous limbs or lymphatic problems as well, you may find that more. So you can see it's quite varying, but there's very few dressings once a week, isn't it? So you can imagine the impact on work there. So moisture, what is moisture? Okay, yes, now I'm not talking about moisture associated with just edema, okay, that's another topic. So yeah, we could be having some moisture on the skin or through the wound from excessive edema or lymphedema, and we have to manage that, I get that, but exudate from a wound we're talking about now can cause, as we've just said about my patient with that distress of licking wounds. But please guys, remember that we need exudate. We don't want a dry wound bed. We need exudate, okay? It's the good guy, it's not the bad guy, because we always associate exudate with bad. Okay, it promotes that healing. It's going to bring vital nutrients, proteases, really good protein building, protein factors for building new cells. We really do need it. It's going to help tissues to migrate to where we need it. What are our cells mainly made up of? Water and fluid. So if we dry out a wound bed, or we haven't got enough exudate there, how can the repair cells migrate to that area? And how can new cells start to form when they're made up of fluid? Okay. It allows autolysis, so that dead or devitalized tissue to start to break down. So if we haven't got that exudate, natural autolysis, which your patients will undertake, you've seen it yourself when you cut yourself, and you start to get that slough appearing, your body's doing a job. Okay, it's trying to break down devitalized tissue, any waste products, so we need it. And then there's really nice, healthy proteases, okay? They're inactive in good exudate, and they're the good guys, and we want those, okay? So it's very often misconstrued as bad, but it's not. Exudate is really important. We remember it, however, when it is bad, okay? And that is, unfortunately, that's how we remember exudate. And it's only bad when it's unmanaged or we can't manage it because of the problems. It's going to contain bacteria and white blood cells. All exudate does, it's a cleanser. But when that bacteria and microorganisms sit on the wound bed for a long period, or the peri-wound skin, it will cause the wound bed to deteriorate and the peri-wound skin to excoriate or macerate, because it's almost burning that healthy tissue, and you can see that on that wound there. Now you can imagine then how painful and debilitating that is for the patient and how much work that will take to try and resolve that problem. Those proteases now that I said were inactive and really helpful and bringing lots of protein are now activated, and this is when they become harmful and cause that reaction with the skin. They're corrosive and it's ongoing if it's not resolved, and it can lead to all sorts of problems, extensive wound damage and sepsis as well. I've talked to you about the problems associated and more. There's many, many more. But all of those frequent dressing changes for you and for the patient, okay, odour, infection, delayed healing, you know, leakage and soiling, all those embarrassing factors as well. We know that slough or devitalised tissue will encourage that exudate production, and larger lower limbs will also mean more fluid in that area. So that edema. Any underlying comorbidities may contribute to that edema, so I'm not taking away the fact of the assessment of the patient as well. Is there any heart failure? Are there any under congestive cardiac failure, respiratory failure, kidney failure that may be linked to that? Work as a wider MDT team to address that. Or inappropriate compression, i.e. no compression and they should have it, or reduced compression and it should really be full, but we'll talk about that afterwards. So a simple exudate pathway, that's in your best practice statement. You can look at those. You can Google, give me an exudate pathway. I'm a big believer, do not reinvent the wheel, share. I will share anything I produced in Shropshire with any of you guys because I'd rather help you and you can adapt it, you can change it and do whatever you would like with it. If you're talking exudate though, one thing I will say is please make sure your secondary dressing is fit for purpose, because if you've got high levels of exudate, you know, a simple pad is not going to work effectively. It will just allow the exudate to sit on the wound bed and sit on the peri-wound skin. Think about your use of superabsorbents. Superabsorbents work in the principle that they're going to take the fluid into the dressing itself and retain it there, so it doesn't then sit on the skin. Superabsorbents are thin. The one we use is the Flivisorb Pro, but you look at your area, what you've got, but they're great under compression and they really are effective, because if you take away that exudate from the, you know, excessive exudate, I should say, into the dressing, you're going to reduce those microorganisms, reduce the peri-wound skin excoriation, as you can see on there, and guess what? The wound can start to heal. Okay, so finally I just want to go through this case study with you. It's an elderly patient with a history of venous disease, extensive ulcer on the outer aspect of the leg, as you can see. Wound's been present for 4 months in reduced compression. Exudate levels are moderate to high. Sorry, I meant to say in pain as well. And the Doppler reading is 0.82. And for those in the audience, that's indicating it's safe to apply compression. Which 2 letters of Times would you address first? Can vote for me. So which 2 first would you probably address if you're looking at the wound I've just shown you, and I will go back to it in a minute. Just going to check time whilst you just check time. That was a good pun, wasn't it? Just whilst you're doing that. Going to finish there because I know it's time for your lunch. So let's just have a quick look. And I think it varies. You'd probably address all of Times, but I'm just saying initially in that wound, the tissue and the moisture I will probably address first, because if you look at it, you know, can you really see the wound bed? Is that tissue healthy or is it devitalised? So you've got to remove it. What's that going to lead to? We've put there, exudate levels are moderate to high. If we address the T and the M first, then hopefully infection burden will be reduced, okay, and the wound will start to heal, okay. And that's right there, and it's, she said, and that's the wound post. And that was no magic answer, that was break down the devitalised tissue, which we did. Well, the patient did herself. It was a older patient, but I had a young patient similar who would self-care. We'll talk about self-care after. I have finished now, Chris. And 6 weeks. But all we did, if you use the Times process, was remove the devitalised tissue, reduce bacterial burden, and yes, she had compression. But we'll talk about compression after lunch, okay? So I'm just going to move on from that one. Similar situation, and I think I'm giving you the answer anyway, that what it was tissue and eye. So, in a nutshell, before your lunch, and I've failed again, running over, is we've looked at introducing the best practice for you if you don't already aware of it, of venous leg ulcers. But no, it's not rocket science, we just give you some tools that might help you in practice. You may already be using a very good, robust tool to help remove the barriers. But if even in your head you're saying times and you're removing those barriers to wound healing, you know, you're 50-60%, in my opinion, as a clinician, at moving that wound onto the healing process. If we just think about the dressing we put on and what compression therapy and don't address the times, I think that's why we've got some wounds that are still there at 2 years. Okay. So hopefully that's okay, and you'll join me after lunch. If not, I'll just cry up a corner. Okay. Any questions? But I think we haven't really got time. But if there is any burning questions, please shout out now. No, because you all want your dinner, don't you? I don't blame you. So I'm here afterwards. So, and my after session should be a little bit shorter. So, thank you very much. Can you leave your voting pads on? Thank you.